Hello, I'm Dr. Humes. This lecture session will go over the cardiovascular system, and what we're attempting to do here is take the American Board of Pediatrics content specifications for the pediatric boards and go over those items and try and give you some basic understanding of the items as they're presented to us that might appear on the pediatric boards. The first and most basic issue is blood pressure measurement, and there are some simple points that we want to make about blood pressure measurement. The first is that you need to choose the proper cuff, and the cuff size should be about 80% of the upper arm circumference. A small cuff, if you use a too small cuff for a patient, this will tend to give falsely high readings, particularly of the systolic pressures. Normal blood pressure range is something that's very age dependent, as you know, and therefore one should be either very aware of those blood pressures or plot them on a blood pressure curve, just as you would heights and weights for smaller children. A blood pressure which is consistently or persistently above the 95th percentile for age requires some sort of evaluation. Now, the question that often comes out of this type of content specification is the issue of the incorrect cuff size, where the question might say that you're getting a high reading in a patient, and the correct answer for the next thing that you should do would be to check the cuff size and make sure that it's proper. If patients become acutely hypotensive, they can develop a hypertensive encephalopathy, and it was felt that you should know the signs and symptoms of hypertensive encephalopathy. These include ataxia, stupor, seizures, and also vomiting. So this constellation of findings should make one think about hypertensive encephalopathy. Pediatric chest pain is a fairly common reason for referral to the pediatric cardiologist. As a matter of fact, it is the second, in our practice, it's the second most common reason for referral after heart murmur. However, having said that, this is rarely a cardiac in origin, and it's much more likely to be a musculoskeletal type of pain or possibly even a pulmonary related pain. Now, if you were to look at this in the cardiologist perspective and look at the potential cardiovascular causes of chest pain in children, you come up with this fairly short list: aortic stenosis, possible coronary problems, including anomalous origin of a coronary, or perhaps a patient who's had previous Kawasaki disease. Pericardial disease is a real possibility for chest pain. Also, use of often illicit drugs can produce some coronary artery spasm and can create a coronary type chest pain. Mitral valve prolapse is a maybe. It's questionable whether mitral valve prolapse is really a part of chest pain. And patients with Marfan syndrome can also have chest pain, but in that case it's usually something relatively serious like a dissecting aneurysm. Now, I think as you can see from this list that the cardiovascular causes of chest pain often have fairly definable origins, either by physical examination or by historical issues. So this is very important in evaluating the patient with chest pain. Syncope is another very common reason for referral to the pediatric cardiologist. This would be our third most common symptom that we get referred to after heart murmur and chest pain. Syncope, of course, is caused by a transient loss of consciousness, which is caused by a transient reduction in cerebral blood flow. This is very often a situational type of problem with a definable or at least an identifiable trigger. Very frequently it is related to some kind of position or positional change, and very frequently this is a disease or a problem which is seen in older children, preteen and teenagers. This is where you're going to see the majority of patients that have syncopal events. Syncope with exercise requires some type of cardiac evaluation. I would add that that chest pain with exercise also is something that probably needs more cardiac evaluation. The possibilities that we look for with exercise are things like a long QT syndrome or an arrhythmia such as supraventricular tachycardia, aortic stenosis, pulmonary hypertension, or the one that we don't want to miss, IHSS or hypertrophic obstructive cardiomyopathy. Now, the evaluation of a patient with syncope can be fairly basic. Most importantly, you need a good history. I think it's very important to take a history in the manner of trying to get the patient to accurately replay the events which occurred immediately before and during and after the syncopal event. You need to know what happened to them earlier in the day, or what time of day it was, what they felt like immediately before the event, how long that feeling persisted before they had their syncopal event. All of these are very important in both how you're going to evaluate and potentially how you're going to treat some of these patients. They also, I think, need an electrocardiogram, and you need to look specifically for the issues of the QT interval and correcting that appropriately. You need to look for the possibility of ventricular hypertrophy, either right or left, and also the possibility of Wolff-Parkinson-White syndrome, or WPW. If your examination is abnormal, if the situation sounds unusual, if it's exercise-related syncope, things like that, I usually get an echocardiogram for abnormal ECG or exercise-related symptoms. A stress test may also be important for exercise-related syncope as well as exercise-related chest pain, because it's an exercise-related symptom, and we want to try and reproduce that as near as we can. Tilt table testing can be used for suspected vasovagal syncope, neurocardiogenic syncope, same thing. However, I don't think that's an absolute must-have test. I think that history is probably adequate to obtain the diagnosis in most of these patients. However, I would reserve tilt testing for those patients in whom the diagnosis is uncertain or the symptoms are a little bit strange, or in those patients where you get to the point where they have enough syncope that you're thinking about prescription medication to treat them. And in that case, tilt table testing can be used to evaluate the efficacy of that medication, giving them a tilt table test before you start the medicine and then repeating it afterwards to see whether you've modified the behavior. Realize that tilt table testing is not positive in all patients with neurocardiogenic syncope. Innocent heart murmurs. Heart murmur certainly is the most common reason that patients present to the cardiologist, and listening to murmurs and identifying murmurs as innocent simply takes time, patience, and practice, particularly practice. You need to listen to a lot of murmurs. You need to identify their sound characteristics as well as their position and how they behave during your physical exam. I don't think it's fair that every patient with a heart murmur should be referred to the cardiologist, but on the other hand, it is what we do, and we don't mind seeing patients with heart murmur at all. The most common innocent murmur that we see is the so-called Stills murmur. This is a vibratory murmur, which is very low-pitched. It is maximal at the lower left sternal border. It tends to increase in the supine position, and it tends to be somewhat output dependent. So in higher output states in young children, infants and toddlers in particular, that's when we often hear these murmurs. I've found that my best description for what the vibratory innocent murmur sounds like is it sounds like corduroy pants rubbing together. So it's that kind of low strumming sort of sound that occurs in this area. One of the test questions that often comes up with this particular murmur is its increase in intensity when the patient lies down, and disappearance when they stand up or sit up. A venous hum can often accompany a vibratory murmur, but it doesn't have to. A venous hum is the sound of blood dropping down through the superior vena cava into the heart. Again, this tends to be a toddler type of murmur. It's unusual to hear this in small infants, often because you're examining small infants in a supine position, and this is one where very much the murmur is affected by gravity. So this is a murmur where the patient needs to be upright or semi-upright for you to hear it most of the time. It's a continuous sound, somewhat musical and high-pitched. It's maximum usually in the upper right sternal border under the clavicle, and again it will disappear with supine positioning, and sometimes you can turn the head one way or another and change the venous blood flow into the SVC, and that will also make the murmur disappear. It's unusual to hear this murmur continuing into school-age children. It usually disappears before school age. With the innocent vibratory murmurs, they can continue to appear into school-age children, but I think the majority of them are probably gone by the end of elementary school. A few of them will remain later than that, particularly if the patient is very thin and doesn't have much sound insulation for their chest. A pulmonary flow murmur is heard at the upper left sternal border. This is a murmur which is, again, somewhat better heard in a supine position. Tends to be somewhat output dependent and is heard a little bit more in older school-age children and even some young teenagers. This is also a murmur which can be affected by things like anemia. So if you have this murmur, it might be a reasonable thing to check the hemoglobin. Again, all of these are benign murmurs. The pulmonary flow, all of these are, the first two are systolic murmurs. The venous hum tends to be a more continuous murmur. As I said, innocent murmurs can occur at any age, especially over the age of 3, but you can hear innocent murmurs in infants. I have heard innocent murmurs in newborn babies in the first 24 hours of age. However, you often don't because their heart rates are high and and they're often fussy, and perceiving the murmur can be difficult. You generally, once you have locked into your brain what innocent murmurs sound like, generally you don't need to do any studies for those. You reassure the patients that the murmur is innocent. You make sure that the parents realize that they don't just have a heart murmur, but they have an innocent heart murmur. You need to label it as such so that they understand that label, because that often doesn't happen in the pediatrician's office. You need to make sure you tell them that they are normal, that they can do anything that any other child can do because they have a normal heart, that there are no restrictions and no need for dental precautions, and that the murmur will eventually go away with time. Cardiac surgery comes up infrequently, but occasionally patients who've had cardiac surgery will present in the pediatrician's office for their routine care, and one should know some of the complications that you can encounter after surgery. So this particular content specification might come to you as a multiple choice question for things that can happen after cardiac surgery. Of course, rhythm disorders, particularly heart block, can occur particularly after the correction of septal defects. Chylothorax or pleural effusions, which can be chylous, can occur after surgery and might produce some respiratory difficulty. There is a post-pericardiotomy syndrome that can occur in anyone who's had the open heart surgery and has had the pericardium opened. It is an inflammatory problem of the pericardium and can occur somewhat late after an otherwise successful cardiac surgery. Obviously, this produces fluid in the pericardium and can produce respiratory distress from tamponade. It could also produce some chest pain. So these symptoms should be looked at carefully. Sick sinus syndrome tends to be a late complication after cardiac surgery, often occurring many years later. This is due to some damage to the sinus node during the surgery. Sick sinus syndrome is most often a bradycardia syndrome, but it can also be a tachybradycardia syndrome, so you can get a lot of odd rhythms with the sick sinus syndrome. Atrial flutter in patients who have had atrial surgery or who have heart disease, which predisposes them to some type of atrial enlargement, can have atrial flutter. Atrial flutter can produce tachycardia, and realize that atrial flutter can occur with some degree of block. That is, the atrium may be going very fast, but not all of the beats are getting through to the ventricle, so there's a block there. And one of the clues to atrial flutter may be a heart rate which is not varying. Your heart rate should vary a little bit from day to day and situation to situation. So these patients, say if they have a flutter at a rate of 300 beats per minute, but there's a 2-to-1 block, you might detect a heart rate of 150, but that heart rate won't change. It won't get less when they are quiet, and it won't get more when they exercise or try to do that. So that doing some more provocative things might bring that out. Valvular insufficiency may also be a part of certain types of heart disease, and one should be aware of that. The complications or the implications of valvular problems depend a great deal on which valve is involved. Congestive heart failure in children is defined a little differently than we see in adults. Children will present more commonly with congestive heart failure due to their congenital heart disease from a left to right shunt. Children may also have congestive heart failure from ventricular or pump failure. Adults will tend to have primarily pump failure, most often due to atherosclerotic heart disease and coronary artery disease. However, regardless of these etiologies, the symptoms can be very similar from one to the other. It usually produces some degree of respiratory symptom, either dyspnea or orthopnea or breathing problems. These are symptoms where one wants to think about heart failure and evaluate them appropriately. In children, they may present with fatigue, exercise intolerance, anorexia in small children. Cough may be a prominent part of this. Additionally, abdominal pain is a fairly common presenting sign in patients who have a pump failure due to things like a myocarditis. I've always been interested in how many patients will present with GI type of symptoms, probably due to decreased perfusion of the gut in patients with more of an acute myocarditis, cardiomyopathy type of situation. And dyspnea, certainly respiratory symptoms can be a big part of this. Also, you can get peripheral edema, but this is an unusual finding in acute heart failure in children. Hepatomegaly is frequently present, however. Jugular venous distension, again, may happen, but is an unusual finding in children, and because smaller children tend to have a lot more fat in their neck, visualizing jugular venous distension can be somewhat difficult. Cardiomegaly on chest x-ray is part of that, and also you can sometimes hear a gallop rhythm. Additionally, tachypnea, tachycardia, and hepatomegaly are commonly seen in infants. Wheezing is a possibility for heart failure in that patient group, and there can be failure to thrive and poor feeding. I think that's a very common finding in patients with that. There is also can be irritability and dyspnea with that. Um, when one suspects heart failure in children, I think that a chest X-ray is a very valuable tool that should be employed here. And obviously, you're looking for cardiomegaly. You're looking at the pulmonary vascular markings because they may be increased from left to right shunt or even from overcirculation heart failure as well as from pump failure. And you're looking for signs of pulmonary edema. An electrocardiogram has probably less diagnostic value, but might be something that you want to consider. You can look for arrhythmias, which might be part of it. There may be some subtle signs of chamber enlargement, but it probably is not as valuable as a chest X-ray overall. And occasionally you see patients with low voltages, which can be a sign of myocarditis. Additionally, if a patient had pericarditis as a result of that, they would have some ST segment changes. So here's a normal chest X-ray that I think you've all seen, and you can see the overall the cardiac silhouette and the cardiothoracic ratio. And I think this is something that getting out a ruler and measuring, or nowadays electronically measuring that, as you know, in most cases this should be under about 50%. Of the heart width should be under about 50% of the chest width at its largest point. And here's a patient with very obvious cardiomegaly and some increased pulmonary vascular markings. Here's a patient with fairly normal looking pulmonary vascular markings and clear cardiomegaly going way over into the right chest makes one think that some of the right atrium here is pushed over into the right chest. And here's a patient where the heart size is somewhat obscured and from what we see may not be all that big, but certainly has a lot of pulmonary vascular markings and pulmonary edema. Arteriovenous malformations are an unusual and fairly rare entity which can cause heart failure in children. Usually, if they are big enough to cause heart failure, you're going to see these in newborns. And when you see it in newborns, these AVMs are going to be relatively large. Intracranial AVMs, such as vena Galen aneurysm, intrahepatic sites are the most common for symptomatic AVMs in children. Here's an area where a stethoscope can be helpful. A loud bruit will often be heard over the site of the AVM, and the blood pressure may show you a very wide pulse pressure. So if you look at again causes of congestive heart failure now in the nursery age group, asphyxia has to be fairly severe asphyxia, and now you have pump failure. Arrhythmias, certainly a possibility, more likely the tachyarrhythmias. Again, as I mentioned, arteriovenous malformations. Neonatal myocarditis does present in these patients, and we need to be aware of that, as well as some of the congenital heart anomalies, hypoplastic left heart syndrome, ductal-dependent anomalies such as interrupted aortic arch after ductal closure, and some of those complete mixing lesions such as truncus arteriosus and possibly some forms of single ventricle. Now, you're going to see the presentation of congestive heart failure in older patients being a little bit of different. Left-right shunts will probably present a little bit later. You're not going to see that as much in the brand new newborn. A simple VSD or a large VSD, AV canal defects, things like that, will probably present a little bit later, and 3 weeks is about the earliest that you'll see that. These often present or peak at around 4 to 8 weeks of age, so you want to be aware of that. SVT can certainly present with heart failure. Anomalous left coronary artery from the pulmonary artery, something that often presents at about 2 to 3 months of age with congestive heart failure symptoms, poor feeding, dyspnea, etc. And acute hypertension, as we mentioned at the early part of this talk, can be something that can cause cardiac symptoms also. As you know, the timing of congestive heart failure in children due to left-right shunts is affected by pulmonary resistance, and pulmonary resistance is generally very high at birth, which is why we don't see heart failure symptoms early on. This drops over the first 6 to 8 weeks of life. In a normal heart, it actually drops fairly quickly. In a heart with a large left or right shunt, it can drop much more slowly to about 6 to 8 weeks before it reaches its normal nadir. The symptoms of congestive heart failure will worsen as that pulmonary vascular resistance drops. Congestive heart management, in general, rest and nutrition. You want to maintain good nutrition through these, which can be difficult because the heart failure symptoms can very much work against you in trying to maintain good nutrition. The content specs still talk about the use of digitalis here. However, I would say practically that I'm hoping that not too many of these questions appear on the pediatric boards anymore. Digitalis may have some role in some pump failure, but really it has very little role in overcirculation failure. And we actually don't even use it all that much in pump failure anymore. It's just not as common a drug given the armamentarium of pharmacology that we have at our disposal for heart failure. Diuretics, however, in any form of heart failure are, probably our first line in taking care of this, and we frequently use Lasix or furosemide, starting in a dose of kind of a mid-range dose of 1 milligram per kilogram twice a day. Adding to that aldactone or spironolactone in a similar dose. This can be very effective in both counteracting the potassium wasting effects of Lasix, as well as it may have some of its own inherent benefits in treating heart failure. Because we don't use as much digoxin now, for a lot of overcirculation heart failure, we've switched to using afterload reduction, particularly with captopril, or now we use a little longer acting medications like enalapril. So these are becoming our mainstay of first-line treatment for congestive heart failure. You should know a little bit about the genetics of congenital heart disease and cardiovascular disease in various syndromes. These always come up as some test questions on the pediatric boards. As you know, in trisomy 21 or Down syndrome, endocardial cushion defects or so-called AV canal defects are the most common, followed very closely by ventricular septal defect, and that one itself is often a test question. Trisomy 18 and trisomy 13 all follow fairly normal inheritance patterns with septal defects such as VSD and ASD and occasionally coarctation. Turner syndrome, which has about 30 to 40% patients with heart disease, have coarctation as the main problem. They also can have aortic valve problems and problems with the aortic root, which can develop along with the coarctation or sometimes separate from it. DeGeorge syndrome, which is the 22q11 microdeletion. DeGeorge syndrome is associated with conotruncal defects such as tetralogy, truncus arteriosus, interrupted aortic arch are commonly seen in DeGeorge syndrome. And fetal alcohol syndrome is associated with ventricular septal defect and atrial septal defect. Now, how does cardiogenic shock manifest itself? We see that with cool extremities, respiratory distress, as I mentioned before, tachycardia, metabolic acidosis, and hypotension. This cardiogenic shock may be that first finding in a newborn with congenital heart disease, and when that occurs, one has to think of ductal-dependent disease. If the infant was well, if we're in the first few days of life, the infant was well, and they suddenly became ill, one has to think that ductal closure might have influenced that, and they may have a ductal-dependent outflow. So you think about things like hypoplastic left heart syndrome and interrupted aortic arch. Severe coarctation may present in the first few days of life, but is typically actually delayed by several days and may present more commonly at 7 to 10 days of age in a lot of patients. Critical aortic stenosis, again, by its definition, critical aortic, even critical pulmonary stenosis, anything that requires the use of the ductus to maintain the circulation on that side of the heart can present early in life with ductal closure. And of course, rhythm problems can also do that, such as SVT. Your evaluation in those, when you suspect those, should include a chest X-ray, an electrocardiogram, and probably fairly frequently an echocardiogram. Now the treatment for almost any type of cardiogenic shock, and if we have a shock here, we're defining that with some hypotension and cardiovascular collapse, means we need to give fluids, regardless of the cause initially, and even before you know that diagnostically. Oxygenation and ventilation are important, and those should be maintained. So it's the basic things that need to be started first. Following that, you need inotropic support with dopamine and or dobutamine, and possibly some afterload reduction with nitroprusside and or milrinone. Additionally, at some point in time, if one suspects congenital heart disease, then prostaglandin E1 should also be considered somewhere in this mix to get that started. There isn't any real problem with giving prostaglandin in most patients if you suspect congenital heart disease. Cyanosis. Cyanosis is defined as the blood reaching a certain level of deoxyhemoglobin. That varies with different authors, somewhere between 3 to 4 milligrams percent. And cyanosis, realizes is a clinical entity. Cyanosis is the skin turning blue. So cyanosis is also affected by things like the hemoglobin. It's also affected by skin tone, the perception of cyanosis. The question that seems to be posed on the boards that they want us to go over is the issue of central cyanosis versus peripheral cyanosis. Central cyanosis you will see in the mucous membranes, in the center of the body, in the lips, and usually reflects that amount of hypoxemia. So you have an overall general cyanosis, whereas acrocyanosis generally will involve the extremities and may reflect perfusion or things that will affect peripheral perfusion. It can often be more demarcated, but the patient in that setting is normally saturated, and this can often be just a transient vasomotor change. Regardless, the patient with suspected cyanosis you should measure this, and the first and easiest thing to do is to get a peripheral oximeter on them and get a pulse ox to see what their saturation is. If you find abnormalities there, then this may and probably should be followed up with a blood gas, most preferably an arterial blood gas. When you suspect cyanotic congenital heart disease, we do a hyperoxia test, and a hyperoxia test is measuring the arterial oxygen levels, your PO2, in a patient on room air, followed by giving them 100% oxygen over 15 minutes. And a positive test is the failure to raise that PO2 above 150 after 15 minutes of 100% oxygen. And you should obtain this from a preductal location, which usually means up in the arms, not down in the legs. Now, the cyanotic congenital heart diseases that we encounter are often taught to remember people because they all start with the letter T. That's not entirely true, so you want to be a little bit cautious of that, but the boards like that little mnemonic, so you want to know the ones that start with T. Those are tetralogy, transposition, tricuspid abnormalities such as tricuspid atresia, truncus arteriosus, and total anomalous pulmonary venous return, particularly obstructed total anomalous pulmonary venous return. Now, interestingly, not all of these entities will present with cyanosis. So they are cyanotic entities by definition, but not all of them will present with cyanosis. Tetralogy is a good example of that. Most patients with tetralogy will probably present with a heart murmur rather than cyanosis, but you should recognize it as being one of the cyanotic defects. Other things such as hypoplastic left heart syndrome, single ventricle, Ebstein's anomaly can also present with some degree of cyanosis and or some degree of cardiovascular collapse with ductal closure, as in the case of hypoplastic left heart syndrome. So, speaking of tetralogy, it is the most common cyanotic form of congenital heart disease, and it's about the fourth most common defect that we see. So it's seen relatively frequently. The issues of tetralogy spells or hypercyanotic spells that can occur with tetralogy is a favorite board question, and you should understand them. This is a sudden increase in cyanosis in the patient with tetralogy. They are often restless because of that and frequently hyperpnic. There really should be two hallmarks of a TET spell. One is hyperpnia, or deep, rapid breathing, and the other is cyanosis. This will often occur after awakening or occurring with crying. You may find that on physical exam that the murmur of pulmonary stenosis typical of tetralogy will disappear when this is happening. It may become very severe. These patients can be, in patients that have profound TET spells, the peripheral oxygen saturation, if you're measuring it at the time, can go down very low, down below 20. I've seen it. So you want to respond to these. And it may progress even to unconsciousness. The treatment for these, very quickly, is knee-chest position. You also want to give them oxygen. You want to give them morphine. You want to use morphine both to decrease the hyperpnia, which is playing into the vicious cycle of a TET spell, as well as relax the patient and give them some venodilation, which can help. You may also want to give them some vasoconstrictors. That can be effective in TET spell. Volume expansion and corrective acid-base abnormalities may be necessary. Therapeutically, if these items don't work, there isn't a lot you can do without the help of a cardiovascular surgeon. Doing a shunt can, such as a Blalock-Taussig shunt, can help in a TET spell. For long-term management of it, beta blockade has been shown to be effective in preventing TET spells in some patients. We don't use that as much nowadays because with good infant surgery, if we're having problems with TET spells, we'll simply do a repair on the patient if that's possible. The prognosis overall in tetralogy, uncorrected, which you hardly see anymore these days, is progressive polycythemia. This can lead to the complications of a right-to-left shunt with polycythemia, such as brain abscess, and they have a fairly high incidence down the road of endocarditis. Corrected, however, they're usually asymptomatic. They have a small but significant number of arrhythmias that can develop, particularly ventricular arrhythmias. And their work capacity may be somewhat less than normal. A lot of this is due to the fact that many patients with tetralogy are corrected with what's called a transannular patch, where the pulmonary valve is incised and a patch placed over it. This results in a fair amount of pulmonary regurgitation, which makes the right ventricle somewhat less efficient, so that can decrease their work capacity. Polycythemia can occur in patients with long-standing cyanotic congenital heart disease. Again, these are not patients that you're going to see very much of these days. We don't have that many uncorrected patients which are around anymore. This will increase their red blood cell mass in response to this chronic hypoxemia, and if it gets high enough, particularly over about a hematocrit of about 65, this will increase their blood viscosity. Common symptoms that they have are a general feeling of malaise in addition to joint pain, fatigue, headache, and dyspnea. And again, some of these questions occasionally come up on the boards. They may have an increased risk of cerebral thrombosis, particularly if they become dehydrated, so they need to keep their fluids up at all times. We think of the polycythemic patient as also being at risk for a relative anemia. One sees, as I mentioned on the previous slide, the polycythemia as a problem but the polycythemia is a response to their condition. If they have hypoxemia and they are relatively anemic, that also can be a problem. So one does not want to see a patient with a low resting saturation have a normal hemoglobin because their oxygen carrying capacity is reduced as a result of that. So you want to make sure that they do not have any type of iron deficiency anemia, and somewhat paradoxically sounding, patients with long-standing polycythemia should probably receive iron therapy to prevent any kind of microcytic anemia. They also, as I mentioned, are predisposed to cerebrovascular accidents. Now, there have been some fairly recent studies on the cognitive outcome of patients with cyanotic congenital heart disease, and it's not altogether encouraging. These patients do have somewhat lower IQs and more behavioral problems. They have a little bit worse perceptual gross motor function than normal or non-cyanotic congenital heart disease patients. The degree, duration, and of this hypoxia will affect the overall outcome. Circulatory arrest is an operative technique that is used in correcting some of these in the operating room, and patients who have undergone circulatory arrest can also have the same type of lower cognitive, behavioral, and school performance issues than controls. Unfortunately, circulatory arrest is necessary in correcting many of these patients, so you just need to be aware that it has some complications associated with it. Well, let's talk about ductal-dependent lesions a little bit. Ductal-dependent, the ductus is not always bad. The ductus arteriosus is necessary for some types of heart defects, particularly outflow obstructions. Outflow obstructions such as hypoplastic left heart syndrome and severe coarctation, which are left heart outflow obstructions. So it may be required for survival. With a PDA and relatively high pulmonary vascular resistance, these patients can be relatively asymptomatic. But when they do have ductal closure, then this will precipitate systemic hypoperfusion, gut hypoperfusion, acidosis, and shock. Ductal dependent may also be present for right-sided obstructive lesions such as pulmonary stenosis or pulmonary atresia. So it's pretty much outflow obstructions that you want to be looking for with ductal dependence. Now, what about the ductus as a problem? Well, of course, we know that the premature infant is more susceptible to continued patency of the ductus arteriosus, and a symptomatic PDA may be present in up to 10% of premature infants. Its clinical manifestations are bounding pulses, wide pulse pressure, hepatomegaly, and cardiomegaly, and they may also have an increased oxygen requirement if they are a ventilated patient. You want to confirm that diagnosis by both physical exam as well as echocardiography, which is a simple bedside test, and initially probably treat with IV indomethacin. In some patients who don't respond to IV indomethacin or who have complications by which indomethacin should not be given, such as renal problems or low platelets, then surgical ligation may be necessary. Ventricular septal defect is the most common type of congenital heart disease that we see. It will present with a usually holosystolic murmur when the pulmonary vascular resistance drops, as I mentioned before, typically at around 3 to 8 weeks. You may hear a loud second heart sound with a large VSD. That loud second heart sound is created by pulmonary hypertension, and as the pressure in the pulmonary artery is high, as the pulmonary valve closes, it will make a louder sound, and that will produce that. You may also find a fairly subtle physical finding in a diastolic flow rumble across the mitral valve. So hearing this at the apex, it's a very short, early sound that takes a bit of practice to hear. You may also hear an increased flow across the pulmonary valve because of the increased pulmonary flow. Generally speaking, the louder the murmur, the smaller the defect. That's a little bit difficult. I think that A very large defect will not have a loud murmur. As the defect starts to get smaller and smaller, the sound will increase, and as the defect gets very, very tiny, however, the overall volume of the sound may go down when it becomes very, very restrictive. As mentioned before, we usually see congestive heart failure symptoms develop, if they're going to develop, by about 3 months of age. An atrial septal defect, again a common left-right shunt, will usually present as an asymptomatic heart murmur. And it's a fairly subtle heart murmur. So one must realize that atrial septal defect is the most common heart disease that we see, which is missed in childhood. So this is an important one for pediatricians because obviously they're missing this one more than others. And it's missed because it's asymptomatic and the murmur is fairly subtle. The murmur is a systolic ejection murmur in the pulmonic region. And you have that murmur in the pulmonic region very simply because the extra flow that's going through the right heart from the ASD reaches a narrow point. And the narrow point in the right heart is the pulmonary valve. When it reaches that narrow point, it becomes somewhat turbulent, and you can hear the sound. Additionally, the pulmonary valve is the most anterior structure of the heart, so it's the closest to the chest wall, which means that you can hear some softer sounds in that area. This will also produce a both wide and fixed splitting of the second heart sound, and again, that's a very important physical finding. If you see that on a test question, you know they're talking about atrial septal defect. Wide and fixed splitting of the second heart sound, fixed meaning it does not vary with respiration. And this happens because of the loss of buffering of pressures between the right and left atriums that normally occurs with respiration. Occasionally, but I think very rarely, you'll hear a similar diastolic flow rumble across the tricuspid valve. That's a very unusual finding in most patients. And even in spite of this, these are rarely symptomatic. If there are any symptoms in ASD, it will be respiratory symptoms, again, because of the increased pulmonary flow, but I think that that's, again, an unusual finding. The clinical findings of patent ductus will vary a bit with age. An older child might present with a heart murmur, and the younger child and the premature infant may present with a wide pulse pressure and bounding pulses. If they have the heart murmur, typically and classically it's a continuous murmur. It's probably one of the only continuous murmurs that we hear. It's heard over the ductal area in the left upper sternal border. A diastolic flow rumble across the mitral valve may also be present in a ductus where it has significant flow. And again, you may have a loud second heart sound if the ductus is large, again because there may be some pulmonary hypertension present and pulmonary valve closure is enhanced. If you have a lot of shunt, ductus can produce profound congestive heart failure. These patients can have some of the worst congestive heart failure that you will see, and it can develop relatively early in life in an otherwise normal infant. Atrial septal defect, or excuse me, aortic stenosis will usually present as a heart murmur. And so one needs to know the murmur of aortic stenosis. The murmur of aortic stenosis is a systolic ejection murmur which is loudest at the upper right sternal border, and it will radiate to the neck. Radiate to the neck because the sound is going up the carotids as the flow goes out the aorta. You may often hear a systolic click, most commonly heard at the apex. This is an opening sound that the aortic valve makes. And it can be fairly subtle, but if you hear if you listen carefully to the first heart sound, and you hear the first heart sound should generally be single. If you hear two sounds, particularly at the apex where you shouldn't hear two sounds, then you might think of that as a click. It often does not have any kind of special sound characteristics. It may sound very similar to the normal first heart sound. The murmur intensity and length of the murmur will increase with the severity of the obstruction, generally speaking. However, in the infant, where they have, by definition, critical aortic stenosis, where they're often in heart failure, you may not get much of a murmur, simply because the left ventricle has failed and it's not able to generate enough pressure to create much of a murmur. Pulmonary stenosis is a relatively common finding in children. This will produce a systolic ejection murmur now at the upper left sternal border, which will radiate to the lungs. Again, there's often a click, which is heard up in the pulmonic area at the upper left sternal border. Again, the murmur intensity and the length of the murmur will increase as the severity of obstruction increases. The second heart sound may be somewhat widely split in this setting, and most pulmonary stenosis will be asymptomatic. There will be those infants with critical pulmonary stenosis where they simply cannot get enough blood flow to the lungs and they go into shock, which can be ductal dependent, but the vast majority of patients with pulmonary stenosis will simply produce an asymptomatic heart murmur. Infective endocarditis, the epidemiology, the thinking on this is changing somewhat, but for now, virtually any congenital heart disease will pose somewhat of a risk for endocarditis. The lifetime risk for a ventricular septal defect has been estimated, unrepaired ventricular septal defect has been estimated anywhere from 3 to 13%. Pooled series of ASPS and VSD suggests a 9.7% risk by the age of 30. Also, endocarditis can be present and maybe more commonly in the modern age with indwelling catheters, devices, certainly prosthetic valves and prosthetic material. Clinical manifestations of infective endocarditis are fever, malaise. These people just don't feel good, and the combination of not feeling well, fever, and a patient with known congenital heart disease should bring this up. The S, as I like to say, the S in SBE is subacute. So these patients are not often acutely ill in the usual sense. It is a subacute illness with some variations in acuity levels as they proceed. They often can have weight loss and fatigue. Interestingly, splenomegaly can be present in a fairly large proportion of patients, and so if you feel a spleen tip, that might be a clue. You may have a new or changing murmur in a small percentage, and you may also have some peripheral signs, particularly if it's endocarditis on the left side of the heart, arthralgias, arthritis. Less frequently seen, Osler's nodes, Janeway lesions, Roth spots, and splinter hemorrhages. The diagnosis is by blood culture. You want to get multiple blood cultures over a 24-hour period. There is a small percentage where blood cultures are negative in 10 to 15%. Also, patients who are pre-treated can have negative blood cultures. So when you suspect endocarditis, you don't want to necessarily rush to treatment. Remember, the S is subacute. These patients are usually not deathly ill, although they don't feel well. So get the appropriate blood cultures first before initiating treatment. Your sedimentation rate, your ESR, may be elevated in a large percentage of patients. That may be a slight but nonspecific clue. You may have a positive rheumatoid factor. There may be some small anemia, and there may be a hematuria. The role of echocardiography is somewhat controversial. Echocardiography is a good test for seeing vegetative lesions if they are present, but echocardiography does not necessarily rule out the presence of endocarditis. Blood cultures are your primary tool here. A negative echo does not rule out endocarditis, and that's important. There has been noted to be a higher sensitivity for transesophageal echo, or TEE, and there's a higher rate of complications with positive echo, such as emboli, congestive heart failure, and death. I would generally say that the echo is something that should be done when endocarditis is suspected strongly. Ideally, one gets your blood cultures, you get a positive blood culture, you get an echo to see the issues there, not necessarily doing everything all at once, but that is not always followed. The microbiology, most endocarditis is streptococci, most commonly strep viridans, and also associated with the mouth flora. Also, enterococci, pneumococci, and beta hemolytic strep are present. Staph is also present on some, more commonly Staph aureus. Less common are gram-negative organisms as well as a fungus such as Candida. The treatment varies, and there are some very good treatises from the American Heart Association on the length of treatment depending on the organism, the minimal inhibitory concentration of the organism, and its location. So this can all be looked up, and one can find where and how long you need to treat, but it varies roughly between 4 and 6 weeks of usually intravenous agents. Bacteriostatic agents are generally contraindicated. You want bactericidal agents, and you can use 2 antibiotics, but you want to use antibiotics which are synergistic agents in the treatment of that. And again, the treatment regimens are fairly well worked out. Persistent positive blood cultures may require looking hard at drug levels or changing therapy. Prophylaxis guidelines have changed. I'm hoping that the boards have changed on this also. It used to be that virtually all congenital heart disease was treated prophylactically for dental work and GI surgery and such. Now most congenital heart disease is excluded from a routine prophylaxis. Those things which are not excluded are foreign material such as prosthetic valves and surgically constructed shunts. Patients who've had rheumatic or other heart disease are still receive endocarditis. A prior history of endocarditis requires prophylaxis, as well as certain complex unrepaired heart disease, particularly those with the right to left shunt. So that is really the short list of patients who receive SBE prophylaxis now in the dental office. The prophylaxis regimen has not changed for a number of years. The standard is amoxicillin in a dose of 50 milligrams per kilogram with a maximum dose of 2 grams. It is given orally 1 hour prior to the procedure. High-risk patients or patients with GI and GU procedures who still require this will get ampicillin and gentamicin. Penicillin allergic patients or chronic or those patients on chronic penicillin prophylaxis will get erythromycin or vancomycin. Rheumatic fever, although less common in this country, is still a somewhat of a favorite test question on pediatric boards. You should know the criteria and issues of rheumatic fever, which we'll go over. Rheumatic fever is produced as a delayed sequelae of upper respiratory infections with group A beta hemolytic strep. As I said, decreased incidence in the developed world. The first attack will usually occur at age 5 to 15. It's very rare in very young patients. The host and the organism factors play a very important role in the development of rheumatic fever. The clinical manifestations are divided into major and minor criteria. The major criteria, and these are things that you should know, are carditis, which means some kind of inflammation of the heart. This can be evidenced by tachycardia. It might be something you see on echocardiogram with decreased heart function or aortic or mitral valve regurgitation. Migratory polyarthritis. The migratory part is important, and it's arthritis, which means swollen joints, not just sore joints. Chorea, typically Sydenham's chorea is a very strong major criteria for rheumatic fever. Subcutaneous nodules and erythema marginatum. And also I've noticed on the boards they like to play some word games with that rash. They like to throw in erythema multiforme as a distractor to try and trick you. So realize that the rash in rheumatic fever is erythema marginatum. The minor criteria are previous rheumatic fever, arthralgia, which means sore joints but not swollen hot joints, fever, and some increased sedimentation rate, CRP, increased white count, and a prolonged PR interval on the electrocardiogram. Now, the classic Jones criteria are you need 2 major or 1 major and 2 minor criteria, plus evidence of a previous strep infection. So you need to have an elevated ASO titer. There are some other measures of looking for previous strep infection also that can be used. The management, you need an echocardiogram when you suspect rheumatic fever to look for cardiac involvement, to look at the possibility of carditis. Bed rest is still a good idea in patients with acute rheumatic fever. You treat them to eradicate the strep infection with a 10-day course of penicillin or erythromycin if they're allergic. Anti-inflammatory agents such as aspirin and corticosteroids are both recommended, particularly for carditis and heart failure management if necessary. Surgical intervention is not employed too much, but there are patients who will have acute valvular problems which might require surgical intervention. Myocarditis, we're not talking about rheumatic fever anymore, but now strictly just myocarditis. Myocarditis can be clinically silent and might lead to fatal events. You should recognize that. In infants, this can present as fever, irritability, tachycardia, respiratory distress, pallor, cardiomegaly on chest X-ray, and acute circulatory collapse. In older children, this may be more subtle and not quite as symptomatic. Again, tachycardia out of proportion to any type of fever, muffled heart tones, gallop rhythm, poor pulses or perfusion, hepatomegaly, pulmonary edema, and or some type of arrhythmia. The laboratory evaluation, one generally looks at try and find viral causes of this, looking at viruses in the stool, throat washings or blood. You should get a CBC and a blood culture, an erythrocyte sedimentation rate, and an echocardiogram. Management of myocarditis is first to try and treat the signs and symptoms of heart failure, as we've already gone over. This is supportive with fluid management, inotropes, and afterload reduction. A vigorous treatment of any arrhythmia that you see, and the overall use of anti-inflammatory agents in myocarditis remains controversial. There are some ongoing studies of their use in of steroids in myocarditis, but thus far it is not a general recommendation to use them. If myocarditis is found in infants, there's a much higher mortality. Patients may fully recover from a bout of myocarditis or may develop a persistent cardiomyopathy, dilated cardiomyopathy later. Pericarditis, again, is an interesting disease. There are two basic types of pericarditis. There is purulent pericarditis and viral pericarditis. There's also, I guess, a third in tuberculous pericarditis. The purulent pericarditis will include Staph aureus and Haemophilus influenza. That, of course, is disappearing a great deal with the vaccine for Haemophilus. Also Neisseria, Pseudomonas, Salmonella, Campylobacter, Listeria, and E. coli less frequently. So the majority of purulent pericarditis that we see now would be probably Staph aureus. Viral myocarditis, most commonly Coxsackie virus or echovirus, occasionally adenovirus, influenza, and some of the others listed here, mumps, varicella, Epstein-Barr virus, and HIV. Tuberculous, always a subtle one that we don't see too much of. Also some non-infectious etiologies of increased pericardial effusion, particularly connective tissue diseases such as JRA and SLE. Kawasaki disease can have a transient myopericarditis during the acute phase. There can be some drug-induced pericarditis associated with procainamide, hydralazine, and isoniazid. There is, as I mentioned before, the post-pericardiotomy syndrome, which occurs after heart surgery. And also you can get pericardial effusions from end-stage renal disease, although this is unusual in the modern age. Most patients with end-stage renal disease are, if they are dialyzed and take care of themselves, it's unusual to see uremic pericarditis. The clinical manifestations can be chest pain, and with that you could get a pericardial friction rub. Now if you have a large pericardial effusion, the sounds are often muffled and the rub can disappear. The chest pain is an important one because we mentioned this is a common symptom, but the chest pain that one sees in the usual chest pain that one sees in children is a brief, non-exertional chest pain, and the chest pain that one sees in pericarditis should be more unrelenting and constant. It is positional, with the patient often preferring a posture of sitting and leaning forward. You may also get fever, and with enough pericardial fluid, and particularly if it is accumulated rapidly, you may get cardiac tamponade. This is evidenced by increased jugular venous pressure and jugular venous distension, tachycardia, respiratory distress, low cardiac output, and the presence of a pulsus paradoxus, which is a greater than 10 millimeter drop in blood pressure with inspiration. The treatment depends on the degree of the symptoms. Drainage, certainly, percutaneous or surgical, can be done. This can also give you some diagnostic as well as therapeutic possibilities. The therapy then will depend on the underlying etiology. If you have antibiotics for purulent pericarditis and anti-inflammatories for viral pericarditis. Bacterial or tuberculous pericarditis may have a higher incidence of developing late constrictive pericarditis, and if that occurs, then the management is surgical. Kawasaki disease is an important disease seen in cardiology, and the signs, symptoms, etiologies, and treatment should be well known by everyone taking the pediatric boards. The diagnostic criteria are fever of at least 5 days duration and presence of 4 of the following features: changes in the extremities such as edema, erythema, or desquamation, polymorphous rash, bilateral non-exudative conjunctivitis, changes in the lips and oral cavity including swollen pharynx, swollen dry or fissured lips, and or strawberry tongue, and also cervical lymphadenopathy. You should exclude other diseases with similar findings. The treatment is intravenous gamma globulin, 2 grams per kilogram as a single infusion over 12 hours. This has decreased the incidence of coronary aneurysms in patients with this therapy from untreated at about 20 to 25% down to less than 5%. Aspirin is also part of this therapy, starting in a high dose with 80 to 100 milligrams per kilogram per day, and following up with a low dose of 3 to 5 milligrams per day after the patient exits the acute phase. This should be discontinued with a normal echocardiogram at about 6 to 8 weeks, continued indefinitely if coronary anomalies persist. Talking now about some of the heart rhythms that we see. The most common pathologic heart rhythm that we see in children is supraventricular tachycardia. It has an association with the Wolff-Parkinson-White syndrome. About 25% of patients with WPW on their electrocardiogram. Remember that WPW is not equal to SVT. WPW is an electrocardiographic phenomenon, but we know that they have a higher incidence of SVT. We also know that about 75% of SVT is found in patients without obvious WPW on their electrocardiogram. It most commonly presents in patients less than a year of age, and about 80% of those who present early in life will resolve spontaneously. The rate that we see is usually fairly stereotypical in the neighborhood of 240 to 280 beats per minute with a narrow QRS complex. Symptoms in older children will include palpitations. Infants will present often with poor cardiac output signs, pallor, diaphoresis, tachypnea, and poor feeding. Here is a graphic representation of supraventricular tachycardia, and of course the rate is all important. This is a rate which exceeds the ability of the normal heart, so you know that this is pathologic. You often do not see definable P waves. This is an example of the Wolff-Parkinson-White syndrome. There are 2 features of WPW which are important to recognize. One is a very short PR interval shown by the lower arrow here. The other is a delta wave. The delta wave here is an upslurring of the R wave in the early portion of it, which is often referred to as a delta wave. Now, this is not necessarily present in all 12 leads on a 12-lead ECG, so it is not a diagnosis that one wants to make on a single rhythm strip. It might be present, but one should get a 12-lead EKG to look for this phenomenon. The treatment of SVT depends on how the patient is doing. If the patient has signs of shock, then one should do a DC cardioversion. Ideally, one would do that with an IV, but I would encourage you all, if you see a patient in shock and they have SVT, they're in shock and getting an IV may be difficult. Shock can be treated by stopping the rhythm, and you want to do that as quickly as possible. So that may be the way to go rather than waiting to start an IV in, say, an emergency room setting. If the patient is stable, and often these patients can be fairly stable, even though their heart rates are quite high, vagal maneuvers can be tried. In children, this is ice to the face, and the ice wants to go probably over the entire face, including the mouth and nose, and held for a period of about 10 seconds. In older children, you can do some variations of Valsalva maneuver, which can be effective in having them self-terminate their tachycardia. The drug which we reach for primarily now is adenosine. This is very effective in producing acute termination of the tachycardia. I would take this opportunity to say that if adenosine is given properly by a very rapid IV push, meaning you get this into the IV in less than a second, followed by a flush, which you get in about a second or less, then you will see something happen on the electrocardiogram. Adenosine always does something to the heart. It's a very, very powerful drug. If it didn't do anything, then you may need to increase the dose. The stated starting dose is 50 milligrams per kilogram. But you want to, going up to a maximum of, actually I think it's 50 micrograms per kilogram, you want to go up to a maximum of 250 micrograms per kilogram. If you don't see the heart rate slow, then you probably haven't given it properly. You should check your IV, give it faster, whatever. Ventricular tachycardia is an unusual rhythm in children. It is more common in postoperative congenital heart disease. The rhythm is regular and wide complex. The rate is usually a little bit less than SVT, in the neighborhood of about 150 and 180 beats per minute. This may be a source of palpitations in a patient, and depending on the frequency, a Holter monitor or an event monitor may be the device you want to use to try and capture this and define it. Ventricular tachycardia requires some type of evaluation and referral to cardiology, even though in some patients it can be a fairly stable rhythm. And it usually requires some type of treatment, such as procainamide, beta blockers, or even amiodarone. Oops. This is a graphic example of ventricular tachycardia, which is you have to have several wide complex beats in a row, more than 3, to call it ventricular tachycardia. General issues of some arrhythmias. If one encounters irregular rhythms, PACs, PVCs, which are intermittent, these are generally benign rhythms, which we do not treat. Very frequently, these are not even perceived by the patient and may be perceived more on physical exam by the doctor and then confirmed by electrocardiogram. Those generally do not require any type of treatment. Bradycardia, if one sees slow heart rate, this registers a lot of concern in pediatricians, but bradycardia has very few pathologic cardiac entities associated with it. Most frequently, it's a sinus bradycardia, and sinus bradycardia is usually a healthy sign, not a pathologic sign. Bradycardia can also be a sign of complete heart block, but that should be easily seen on the electrocardiogram. And it may also be a sick sinus syndrome, as I mentioned earlier, but sick sinus syndrome would be unusual, a very unusual finding in a patient who has not had previous heart surgery. Tachycardia, as an issue, has many more possibilities, and tachycardia is more likely to be associated with some type of pathology and probably requires some type of evaluation. You need to define the tachycardia, and then you need to find the etiology. Long QT syndrome is a genetic defect leading to abnormal cardiac myocyte repolarization. There have been, and ultimately can lead to ventricular arrhythmias, which can be deadly. There are 6 identified genes. There are 2 inherited forms of long QT syndrome which are described, the Romano-Ward syndrome, which is an autosomal dominant with incomplete penetrance. This has a very prolonged QT interval and is associated with syncope and sudden death. And there is the Jervell-Lang-Nielsen syndrome, which is autosomal recessive, which also has a sensory neural deafness association. Here's an example of a patient with long QT syndrome. You can see that here is an P and an R wave, and you can see the T wave is very, very prolonged here in all of these. It often also has a somewhat unusual, bizarre appearance. This patient also has some ectopy, some PVCs happening. So how do we check the QT interval? Well, we want to measure from the onset of the Q wave to the end of the T wave. That's the QT interval. But since this can vary with heart rate, we need to correct this for the heart rate. And to correct it for the heart rate, we take the RR interval, the preceding RR interval, and we take the square root of that. All these measurements are in seconds, and that gives you your QT interval. Our normal QT intervals should be less than 0.44 seconds, borderline 0.44 to 0.6, and we call prolonged greater than 0.46. Now there are some diagnostic criteria which have been applied to help us with this long QT interval, not unlike the Jones criteria for rheumatic fever. You get certain point scores for having certain things, as you can see here. If you have a very prolonged QT, you get 3 points, less 2 points. If you have a torsade de pointe, which is the ventricular tachycardia, which can occur with this, you get a couple of points, and on down the road, syncope with stress, without stress, etc. Accumulate enough points, and you have the long QT syndrome. And this was also included on the handout, which is with this disc. Irregular rhythms, as I said before, most irregular rhythms are benign. Premature atrial contractions are very common in the fetus and newborn. They may conduct normally and just be a premature beat. They may conduct aberrantly and produce a wide QRS. They may be non-conducted and blocked to the ventricle. There's generally no treatment necessary for these. The same can be said of premature ventricular contractions in isolation. We may treat them a little bit differently in a patient who's had surgery, particularly surgery on the ventricle. Here's a premature atrial contraction. You can see that the P wave axis changed. We have an upright P wave here, and now we have a premature beat, which was preceded by a different looking P wave, which in this case is retrograde. In this patient, in this premature beat, we see a P wave which occurs both prematurely, but it occurs at the end of the T wave here. At that time, the ventricle was not quite completely repolarized, and this conducts aberrantly. If the P wave now occurring very early on the T wave, the ventricle is not repolarized at all, so this would be a blocked PAC, because you can see it produces no R wave. Here are ventricular premature contractions, which again are often wide QRS complexes, which can go in the opposite direction of the R wave, although that's not an absolute finding. Marfan syndrome is an entity which has cardiovascular issues associated with it, as you know. It is a systemic connective tissue disease with autosomal dominant inheritance. It is a defect in the fibrillin 1 gene. There is a reduced life expectancy in Marfan's patients due to cardiac involvement. It is by far the the cardiac problems are by far the most deadly problems for Marfan's patients. These include aortic rupture and dissection or valvular regurgitation. Prior to aggressive surgical management of Marfan's patients and beta blocker treatment, the average age of death was surprisingly about 32 years. Marfan's syndrome have features which involve the skeletal system, such as listed here, pectus excavatum or carinatum, a reduced upper-lower segment ratio, and a very long arm span, greater than height. They have long spindly fingers, arachnodactyly. They have scoliosis, reduced extension of the elbow, with joint hypermobility and joint dislocations. They often have a high arched palate and crowding of the teeth, and they have some typical coarse facial features. They also have eye features. They have dislocated lenses or ectopia lentis. They can have spontaneous pneumothorax and sometimes apical blebs. They can have funny skin findings of striae atrophica, which are not associated with weight gain. And they can have recurrent or incisional hernias. From a cardiovascular standpoint, we worry about the aorta. Primarily, they get dilation of the aortic root, and with that, they can have aortic dissection, which can be catastrophic. They can also have associated mitral valve prolapse, which can have the typical findings of mitral prolapse. The diagnostic criteria are called the Ghent criteria. Again, they're much like the Jones criteria, where you can have you have major criteria in 2 different organ systems and involvement of a third organ system for the index case. For the relative of an index case, you need so you already have then a family criteria of a family history of Marfan syndrome, and you need to have just one major criteria in an organ system and involvement of a third. I would encourage you all, if you're interested in this, to go to the Marfan syndrome website at www.marfan.org, where they have an extensive set of information. They have the checklist about the diagnosis of Marfan syndrome if you're considering it in a patient. And that's the end of my talk today. On this disc, which we are putting together for the residents, there will also be a printable paper handout, one of which includes a copy of the content specifications from the American Board, and the second of which has a paper outline for all of the things that I've shown you here today. Thank you very much.